Hello, and thank you for streaming May's webinar. My name is Erin Frith, and I'm a Risk Adjustment Coding Auditor here at Mount Carmel Health Partners, and I will be your host for today's webinar. We are excited to dive into this month's topic of HIV/AIDS, but first, I'd like to cover some logistics. As you know, Health Partners is providing a small incentive for your time and attention. In order to receive your payment, we ask that you watch this presentation in its entirety within 60 days of its post date. Please fill out the webinar attestation and W-9 and return to Health Partners no later than August 24th. We encourage you to watch the content at any time, but you will only be eligible for an incentive through August 24th. Now let's get started. Our speaker today will be Dr. Paul Bennett. Dr. Bennett is a physician liaison with Health Partners and a board certified in family medicine. He retired from his practice in Grove City in 2018 after 12 years. Prior to that, he was a primary care physician in Southern California for 24 years. He was in practice with strong managed care focus and full risk contracts. Welcome, Dr. Bennett.
Thank you, Erin. It's a pleasure to be here today to discuss this topic. Before we start discussing the specifics of today's webinar, let's review some risk adjustment essentials. Risk adjustment is a methodology by which CMS determines how to allocate resources to Medicare Advantage plans for patient care. There are many factors that determine resource allocation, both demographic and clinical. Demographic examples include patient age, patient gender, institutional status, Medicaid status, and reason for being Medicare eligible. Clinical factors include chronic conditions that have been shown in CMS data to require more resources. There are 70,000 diagnosis codes in ICD-10. Every year, each code is evaluated using CMS data to determine which codes utilize more resources. Once that is done, the data is normalized so that the average Medicare Advantage patient has a risk score of 1. Around 9,500 diagnosis codes are determined to affect risk, and they each map to what is called a hierarchical condition category, or an HCC. An HCC is a group of chronic condition diagnoses that are clinically similar and have been determined to have a similar effect on resource utilization, what is called their weight. These weights are what calculate the clinical portion of a patient's risk score. There are 86 HCCs included in the 2022 risk adjustment model. Telehealth has become an essential part of delivering healthcare during the COVID-19 pandemic. For these visits to count towards annual HCC code capture, they must be performed by an approved provider and include synchronous audio and visual capabilities. The documentation needs to state that these capabilities were used in order to qualify for HCC gap closure. Now that we've covered the basics of risk adjustment, let's continue to the HIV/AIDS content. Human immunodeficiency virus, HIV, is a retrovirus transmitted through blood or bodily fluids that slowly destroys the body's ability to fight infection, allowing for lymphomas, other malignancies, and opportunistic infections to develop or worsen. It is known that 1 in 8 patients with HIV are unaware of their status. Many patients suffer from this condition for years before they receive a diagnosis. HIV/AIDS can be broken down into 3 stages shown below: acute HIV infection, chronic HIV infection, acquired immunodeficiency syndrome, AIDS. The acute stage is the first stage of an HIV infection and typically develops within 2 to 4 weeks after infection. In this stage, the virus replicates and spreads rapidly, resulting in a very high HIV blood counts and high risk of HIV transmission. The increase of the HIV count during the acute stage causes patients to present with flu-like symptoms, fever, headache, rash. Chronic HIV is the second stage, in which the HIV continues to multiply in the body, but at much lower levels. Patients in this stage may not have any symptoms at all. Although there is no cure for HIV/AIDS, medications, antiretrovirals or ART, can slow or prevent patients from advancing in the disease. The main goal is to reduce a patient's viral load to an undetectable level. Once this undetectable level is reached, patients have effectively no risk of sexually transmitted HIV to their partners. Without ART, patients typically regress to AIDS within 10 years, though some progress faster. Patients who are taking ART exactly as prescribed can stay in this stage for decades and effectively have no risk of sexually transmitting to a partner. AIDS is the final stage in which the patient's immune system is severely damaged and the patient struggles to fight off opportunistic infections. A patient with HIV is diagnosed with AIDS if their CD4 count is less than 200 cells per cubic millimeter, or if they are suffering from specific opportunistic infections. Once a patient progresses to this stage, they have a very high viral count, making it easier to transmit to others. Without ART, patients in this stage typically survive 3 years. It is best practice to select codes to the highest level of specificity that makes sense with the patient's burden of illness. Patients should not code for HIV, providers should not code for HIV without confirmed positive test result. When treating asymptomatic patients who test HIV positive, providers then can use code Z21, asymptomatic HIV infection status. For coders, Z21 is selected if the provider does not document any symptoms, but states HIV positive, known HIV, or HIV test positive anywhere in the documentation. B20 can be used for all types of HIV infections, and additional codes can be added for each manifestation. There is no requirement to include additional codes with B20, but if these manifestations are discussed during the visit and mentioned in the documentation, it's best practice to include them in the claim. Patients who receive treatment can become asymptomatic. However, once a patient receives the diagnosis of B20, they cannot go back to Z21. Z21 is reserved for those patients who have never experienced symptoms. On this slide, we see a list of some of the common AIDS-related diagnoses, but this list is not exhaustive. Opportunistic infections are illnesses that occur more frequently and can be life-threatening in people with HIV as their CD4 count falls. Although opportunistic infections may decline in patients with effective HIV treatment, patients with HIV are still more susceptible. Some HIV patients still develop opportunistic infections when they do not even know they have HIV. It may not be an HIV treatment, or treatment is not working properly. Most life-threatening opportunistic infections occur when the CD4 count falls below 200 cells per cubic millimeter. The CDC developed a list of more than 20 opportunistic infections that are considered AIDS-defining conditions. Patients with a lab-confirmed HIV test and one or more of these opportunistic infections will be diagnosed with AIDS regardless of the CD4 count. This slide displays the various ICD-10 codes in their HCC categories and some of the associated weights. And those weights are significant. So you can see why it's very important to properly diagnose what is going on with the patient so that the burden of illness the patient is facing can be appropriately recompensed to the insurance plan. Slide 11. For undiagnosed patients, testing is the first step to improve quality of life, length of life, and prevent unintentional transmission. If a patient is being seen to determine their HIV/AIDS status, use code Z11.4, Encounter for Screening for Human Immunodeficiency Virus. Z71.7 is a counseling code that can be used if counseling is provided to the patient during the encounter for a test. If a patient is experiencing signs and symptoms during testing appointment, the codes, the signs and symptoms, code the signs and symptoms first, followed by the Z71.7. This code is also used if patients return for their test results and the results are negative. R75 can be used if the test results are inconclusive, but there is no definitive diagnosis or manifestations of the disease. If a patient's HIV is managed on antiretroviral medications, providers should use B20 followed by Z79.899, other long-term current drug therapy, to reflect the treatment. Mother-to-child transmission or perinatal transmission can occur in pregnancy, childbirth, and breastfeeding. With the use of HIV medications throughout pregnancy, the likelihood of transmission becomes less than 1%. Mothers with high viral loads should have a scheduled C-section to greatly decrease the risk of perinatal transmission. Newborns delivered to HIV-positive mothers take on the mother's HIV diagnosis due to their antibody status. Newborns can maintain that HIV-positive status up to 18 months after delivery. When coding an HIV/AIDS positive pregnancy or delivery, code O98.7 first, followed by B20 or Z21, depending on the patient's status. Each condition listed on the claim must be supported by at least one element of meat. On this slide, we give several examples of the type of documentation needed for an HIV/AIDS diagnosis to be considered substantiated. Examples of HIV/AIDS meat include status updates, any signs and symptoms. Signs and symptoms are coded first, followed by B20, linking medications, or linking related conditions. Here are some takeaways from today's presentation. Although most primary care providers will refer their patients to specialists, primary care providers are considered the gatekeepers. And even though these patients are regularly seen as specialists, primary care providers should code and document chronic conditions like HIV/AIDS once per year. Patients can go from Z21 to B20, but never go from B20 to Z21. Z21 is specifically reserved for patients who have never experienced symptoms. Although patients can become asymptomatic through adherence to medication, once they have been diagnosed with symptomatic HIV, this diagnosis continues with them for the rest of their life. If patients have any related conditions, code B20 first, followed by the related condition. On this slide are our disclaimers for today's presentation. And then I'll turn it over to Aaron.
Please feel free to send questions to any of the people listed below, and we will be happy to answer. Remember to return your attestation documents to Desiree Corbin by August 24th. Thank you for taking the time to watch this webinar. We hope this has made you more comfortable with coding and documenting HIV/AIDS.